Hello friends, today we are going to discuss the question which was asking DRNB Critical Care Exam April 2023, that is classify and evaluate beta-lactam group. So penicillin was the first antibiotic to be used clinically in 1941. It was a miracle drug, that least toxic drug of its kind was the first to be discovered. It was originally obtained from the fungus Penicillium notatum, but the present source is highly yielding mutant of P. chrysogene. Now about mechanism of action, all beta-lactam antibiotic interfere with synthesis of bacterial cell wall. Beta-lactam antibiotic inhibit transpeptidase so that cross-linking does not take place. These enzyme and related protein constitute the penicillin binding protein, which have been located in the bacterial cell wall membrane. Each organism has several penicillin binding protein, and penicillin binding protein obtained from the different species differ in their affinity towards different beta-lactam antibiotics. This fact probably explains their differing sensitivity to various beta-lactam antibiotics. When susceptible bacteria divide in the presence of beta-lactam antibiotics, cell wall deficient form are produced because the interior of the bacterium is hyperosmotic, and cell wall deficient forms swell and burst, called the bacterial lysis. This is how beta-lactam antibiotic exert bactericidal action. Under certain conditions and in case of certain organisms, bizarre shaped and filamentous form which are incapable of multiplying result. So grown is hyperosmotic medium and globular giant form and protoplast are produced. Lytic effect of these antibiotic may also be due to depression of some bacterial autolysin which normally function during cell division. Rapid cell wall synthesis occur when the organism are actively multiplying, and beta-lactam antibiotic are more lethal in this phase. The peptidoglycan cell wall is unique to bacteria. No such a substances is synthesized by higher organisms. This is why penicillin is practically non-toxic to man. In gram-positive bacteria, the cell wall is almost entirely made up of peptidoglycan, which is more than 50 layer thick and extensively cross-linked, so that it may be regarded as single giant mucopeptide molecule. In gram-negative bacteria, it consists of altering layer of lipoprotein and peptidoglycan. This may be the reason for higher susceptibility of gram-positive bacteria to penicillin G. Blood, pus, and tissue fluid do not interfere with the bacterial action of beta-lactam antibiotic. Now about penicillin G. Penicillin G is the narrow spectrum antibiotic and activity is limited primarily to gram-positive bacteria and few gram-negative one and unable. Now about bacterial resistance, many bacteria are inherently sensitive to penicillin G because in them the target enzyme and penicillin binding protein are located deeper under lipoprotein barrier where penicillin G is unable to penetrate or have low affinity for penicillin G. The primary mechanism of acquired resistance is the production of penicillins. Penicillinase, it is narrow spectrum beta lactamase, which opens the beta lactam ring and inactivate penicillin G and some closely related congeners. Majority of Staphylococci and some strain of Gonococci, Bacillus subtilis, E. coli, H. influenza, and few other bacteria produces penicillin. Gram-positive penicillinase producers elaborate these large quantities of this enzyme, which diffuses into surrounding and gram-negative bacteria, penicillin is small quantity, but it's strategically located in between lipoprotein and glycan layer of cell. Staphylococci penicillinase is inducible and methicillin is the important inducer. While gram-negative organism, it is mostly constitute the enzyme. Some resistant bacteria become penicillin tolerant and not penicillin destroyed. These target enzymes are altered to have low affinity for penicillin. Highly resistant pneumococci isolate in some area have altered PBP. The methicillin-resistant Staphylococcus aureus have acquired PBP, which has low affinity for beta-lactam antibiotic. Some penicillin-resistant pneumococci and enterococci have altered PBP. The low level of penicillin-resistant gonococci are less permeable to drug, while high degree of resistant one produces penicillinase, as do highly resistant H. influenza. Both these appear to have acquired penicillinase plasmid by conjugation and transduction and propagated by its selection. The gram-negative bacteria have pore-in channel formed by a specific protein located in their outer membrane. Permeability of the various beta-lactam antibiotics through this channel differs. Ampicillin and other membrane which are active against gram-negative bacteria cross the pore-in channel and much better than penicillin G. Some gram-negative bacteria become resistant by loss or alteration of pore-in channel. Now, adverse effect. Penicillin G is the most non-toxic antibiotic. It may cause local irritancy and direct toxicity. Some may complain of pain at IM injection, nausea on oral injection, thrombophlebitis of injected vein. Toxicity to the brain can be manifested as mental confusion, muscular twitching, convulsion, coma when very large doses are injected IV, especially in patients with renal insufficiency. Bleeding has also occurred with such a high doses due to interference with platelet function. Intrathecal injection of penicillin G is no longer recommended because it has caused arachnoiditis and degenerative changes in spinal cord. Accidental IV injection of procaine penicillin produces CNS stimulation, hallucination, and convulsion due to procaine. Being insoluble, it may cause microembolism. Hypersensitivity. These reactions are major problem in the use of penicillin. An incidence of 1% to 10% is reported. Individuals with allergic diathesis are more prone to develop penicillin reaction. Penicillin G is most common drug implicated in allergic reaction, because of which it has practically vanished from the use. Frequent manifestation of penicillin allergy are rash, itching, urticaria, fever. Wheezing, angioneurotic edema, serum sickness, and exfoliative dermatitis are less. Anaphylaxis is rare. All forms of natural and semi-synthetic penicillin can cause allergy, and it is more commonly seen after parenteral than the oral administration. Incidence is highest with the procaine penicillin. Penicillin hypersensitivity is unpredictable. Now, the next common side effect is superinfection. This is rare because with penicillin G, because of its narrow spectrum, though bowel and respiratory cutaneous microflora does undergo changes. Then Jerris-Hexmer reaction. It is occur when the penicillin is injected into the syphilitic patient. It is manifested as shivering, fever, myalgia, exacerbation of lesion, and vascular collapse. This is due to sudden release of spirochecal lytic product lasts for 12 to 72 hours. The uses are streptococcal infection, pneumococcal infection, meningococcal infection, gonorrhea, syphilis, diphtheria, tetanus, gas gangrene. Now about semisynthetic penicillin. Semisynthetic penicillin are produced by chemically combining specific side chain or by incorporating specific precursor to the mold culture. Procaine penicillin and benzathine penicillin. These are the salt of penicillin G and not semisynthetic penicillin. The aim of producing semisynthetic penicillin has been overcome the shortcoming of penicillin G, which are poor oral efficiency, susceptibility to penicillinase, narrow spectrum activity, and hypersensitivity reaction. Now, classification are acid resistant alternative to penicillin G, that is phenoxymethyl penicillin, that is penicillin V. Penicillin is resistant penicillin, that is methicillin, cloxacillin, dicloxacillin. Extended spectrum penicillin, that is aminopenicillin, carboxypenicillin, uridopenicillin. Beta lactamase inhibitors are clownic acid, sulbactam, tazobactam. Now about penicillin V, that is acid resistant alternative to penicillin G. It differs from penicillin G in that it is acid state. Oral absorption is better and the peak blood level is reached in 1 hour. TF is 30 to 60 minutes. The antibacterial spectrum of penicillin V is identical to penicillin G, but it is about 1/5 as active against Neisseria and other gram-negative bacteria and anemia. It cannot be depend upon the most serious infection and it is used only for streptococcal pharyngitis, sinusitis, otitis media, prophylaxis of rheumatic fever. Penicillin is resistant penicillin. These congeners have side chain that protect beta-lactam ring from attack by staphylococcal penicillins. However, this also partially protect the bacteria from beta-lactam ring. Non-penicillinase producing organisms are much less sensitive to this drug than the penicillin G. Their only indication is infection caused by penicillinase producing staphylococci, for which they are drugs of choice, except in areas where methicillin resistant Staphylococcus aureus has become prevalent. These drugs are not resistant to beta lactamase produced by gram negative bacteria. Methicillin, it is highly penicillinase resistant but not acid resistant, must be injected. It is also inducer of penicillinase production. MRSA has emerged in many areas. These are insensitive to penicillinase producing penicillin, but to other beta lactam as well as to erythromycin, aminoglycoside, and tetracycline. MRSA has altered penicillin binding protein which do not bind the penicillin. So the drug of choice for this organism is vancomycin and linezolid, but ciprofloxacin can also be used. Hematuria, albuminuria, and reversible interstitial nephritis are specific side effects. Now about cloxacillin and dicloxacillin, it is isoxazoline side chain and it is highly penicillinase as well as acid resistant. It has activity against penicillin G sensitive organism is weaker and it should not be used as substitute for penicillin G. It is more active than the penicillin against penicillinase producing staph but not against MRSA. Cloxacillin, dicloxacillin are incompletely but dependently absorbed from the oral route, especially if taken in the empty stomach. It is more than 90% plasma protein bound and elimination occurs primarily by kidney and also by liver. Plasma THF is about 1. Extended spectrum penicillin. These are semi-synthetic penicillin and are active against variety of gram-negative bacilli. These are grouped according to the spectrum of activity. Aminopenicillin, this group led by ampicillin and has amino substitution in their side chain. Some are product and all have quite similar antibacterial spectrum. None is resistant to penicillinase and to other beta lactams. Ampicillin, it is active against all organisms sensitive to penicillin G. In addition, many gram-negative bacilli, for example, H. influenza, E. coli, Proteus, Salmonella, H. pylori, are inhibited. However, due to widespread use, many of them have developed resistance. Ampicillin is more active than the penicillin G for Streptococcus viridans, Enterococci, Listeria, and equally active for pneumococci, gonococci, meningococci, but less active against the other gram-positive organisms. Penicillin is are not affected and as are other gram-negative bacilli such as Pseudomonas, Klebsiella, indole-positive Proteus, anaerobes like Bacteroides fragilis. Uses are urinary tract infection, respiratory tract infection, meningitis, gonorrhea, typhoid fever, bacillary dysentery, cholecystitis, subacute endocarditis, H. pylori, septicemia, mixed infection. Adverse effect is diarrhea. Ampicillin is incompletely absorbed, so unabsorbed drug irritates the lower intestine. It produces the high incidence of rashes, especially in patients with AIDS, EB virus infection, and lymphatic leukemia. Concurrent administration of allopurinol also increases incidence of rashes. Sometimes the rashes may not be allergic but toxic in nature. Patient with history of immediate type of hypersensitivity to penicillin G should not be given ampicillin as well. Now becampicillin, it is a ester product of ampicillin which is nearly completely absorbed from GI tract and it is largely hydrolyzed during absorption. Thus higher plasma levels are attained. Incidence of diarrhea is claimed to be lower because of lesser alteration in intestinal ecology. Amoxicillin, it is a closer congener of ampicillin, similar to it in all respects except or oral absorption is better, food does not interfere with absorption, higher and more sustained blood levels are produced. Incidence of diarrhea is low. It is less active against Shigella and H. influenza. It is more active against penicillin-resistant Streptococcus pneumoniae. Many physicians now prefer it over ampicillin for bronchitis, urinary tract infection, subacute bacterial endocarditis, and gonorrhea. It is component of triple H drug eradication regimen for H. pylori. Now about carboxypenicillin, that is carbacillin. It is a special feature of penicillin congener in its activity against the Pseudomonas aeruginosa and indole positive protease, which are not inhibited by penicillin G and aminopenicillin. It is less active against Salmonella, E. coli, Enterobacteria, while Klebsiella gram-positive cocci are unaffected by it. Pseudomonas strain less sensitive to carbanicillin have developed in some area, especially when inadequate doses have been used. Carbanicillin is neither penicillin resistant nor acid resistant. It is inactive orally and is excreted rapidly in the urine. It's used as sodium salt in the range of 1 to 2 gram IM and 1 to 2 gram IV every 4 to 6 hours. At higher doses, enough sodium may be administered to cause fluid retention and CH. High doses may also cause bleeding by interfering with platelet function. This appears to result from perturbation of agonist receptor on platelet surface. The indication of carbanicillin are Pseudomonas proteus, burns, urinary tract infection, septicemia, but piperacillin is now mostly used. Carbanicillin may be combined with gentamicin. The two should not be mixed in same syringe. Now the next drug is uridopenicillin, that is piperacillin. It is an anti-pseudomonal penicillin and about 8 times more active than the carbanicillin. It has good activity against Klebsiella, many Enterobacteriaceae, and some bacteriaceae. It is frequently employed for treating serious gram-negative infection in neutropenic and immunocompromised or burn patients. Elimination THF is 1. Concurrent use of gentamicin or tobramycin is advised. Now about beta-lactamase inhibitor. Beta-lactamase are the family of enzymes produced by many gram-positive, gram-negative bacteria that inactivate beta-lactam antibiotic by opening beta-lactam ring. Different beta-lactamases differ in their substrate affinity. Three inhibitors of these enzymes are clownic acid, sulbactam, and tazobactam. Clownic acid is derived from Streptococcus claungerus. It has beta-lactam ring but no antibacterial activity of its own. It inhibits wide variety of beta-lactamase produced by both gram-positive and gram-negative bacteria. Clownic acid is progressive inhibitor. Binding with beta-lactamase is reversible initially but become covalent later. Inhibition increasing with time. Called suicide inhibitor, and it gets inactivated after binding to the enzyme. It permeates the outer layer of cell wall of gram-negative bacteria and inhibits periplasmically located beta-lactamase. So uses addition of clownic acid re-establish the activity of amoxicillin against the beta-lactamase producing resistant Staphylococcus aureus, H. influenza, Neisseria gonorrhoeae, E. coli, Proteus, Klebsiella, Salmonella, and Shigella. Through bacterial flagellates and Bramnella catarrhalis are not responsive to amoxicillin alone. They are inhibited by combination. Clownic acid does not potentiate the action of amoxicillin against the strain. They are already sensitive to it. So co-amoxiclav is indicated for skin soft tissue infection, intra-abdominal gynecological sepsis, urinary, biliary, and respiratory tract infection, especially when empirical antibiotic therapy is to be given for hospital-acquired infection. Gonorrhea single dose amoxicillin 3 gram and clownic acid 0.5 gram probenecid is highly accurate. Adverse effects are the same as for amoxicillin alone, but GI tolerance is poor. Other adverse effects are candida stomatitis, vaginitis, and rashes. Some cases of hepatic injury have been reported. Now about sulbactam, it is semi-synthetic beta-lactamase inhibitor related chemically as well as in activity to clownic acid. It is progressive inhibitor and highly active against class 2 to 4, 5, but poorly active against class 1 beta lactams. On the weight basis, it is 2 to 3 times less potent than clownic acid for most type of the enzyme, but same level of inhibition can be obtained at higher concentration achieved clinically. Sulbactam does not induce chromosomal beta lactamase, but clownic acid can induce some of them. Oral absorption of sulbactam is inconsistent, therefore preferably given parenteral. It has been combined with ampicillin for the use against beta lactamase producing resistant strain. Absorption for its complex salt with ampicillin, sultampicillin uh, to select is better, which is given oral. Indications are gonorrhea. Sulbactam per se also inhibit gonorrhea. Mixed anaerobic aerobic infection, intra-abdominal, gynecological, surgical, soft tissue infection. Now about tazobactam, it is another beta-lactamase inhibitor. Its pharmacokinetics matches with the piperacillin with which it has been combined for use in severe infection like peritonitis, pelvic, urinary, respiratory infection caused by beta-lactamase producing bacilli. However, the combination is not active against piperacillin-resistant Pseudomonas because tazobactam does not inhibit inducible chromosomal beta-lactamase produced by Enterobacterus. It is also of no help against Pseudomonas that develop resistance by losing permeability to penicillin. Now about cephalosporin. These are the group of semisynthetic antibiotic derived from cephalosporin C, obtained from fungus cephalosporin. These have conventionally divided into four generations. This division has chronologically sequence of development, but more importantly takes into consideration the overall bacterial spectrum as well as patency. All cephalosporin are bactericidal and have some mechanism of action action as penicillin, that is inhibition of bacterial cell wall synthesis. However, they bind to the different protein than those which bind penicillin. This may explain the differences in spectrum, potency, and lack of resistance. Acquired resistance to cephalosporin could have some basis as for penicillin. That is alteration in target protein, reducing affinity for antibiotic, impermeability to antibiotic or its efflux so that it cannot reach to site of infection, elaboration of beta lactamase which destroys specific cephalospore. Though the incidence is low, resistance has been developed by some organism even against third generation compounds. So individual cephalosporin differ in their antibacterial spectrum, relative potency against specific organism, susceptibility to beta-lactamase elaborated by different organism, pharmacokinetic properties may have to be injected and some are oral, majority are not metabolized and are excreted rapidly by the kidney. They have short T-half. Probenecid inhibits their tubular secretion. So this is the classification. First generation cephalosporin, parenteral includes ceftazoline, oral includes cephalexin, cefadroxil. Second generation cephalosporin includes parenteral cefuroxime, cefoxitin, oral includes cefaclor, cefuroxime, azatil, and cefprozil. Third generation cephalosporin, parenteral includes cefotaxime, ceftriaxone, ceftriaxone, ceftazidime, and cefoperazone. Oral includes cefixime, cefpodoxime, proxetil, cefdinir, ceftibuten, ceftamet pivoxil. Fourth generation includes cefepime and cefpiro. About first generation cephalosporin, they were developed in 1960 and have high affinity, high activity against gram-positive, but weaker against gram-negative bacteria. Cefazolin, it is a prototype of first generation cephalosporin that is active against most penicillin G sensitive organism, that is streptococci, gonococci, meningococci, then Corynebacterium diphtheria, H. influenza, Clostridium, Actinomyces. Activity against the Klebsiella, Moraxella catarrhalis, E. coli is relatively high but is quite susceptible to staphylococcal beta lactams. It can be given IM as well as IV and has longer T half due to slower tubular secretion and attains high concentration in plasma and in bile. It is preferred parenteral first generation cephalosporin, especially for surgical prophylaxis. Cephalexin, it is most commonly used orally effective first generation cephalosporin, similar to spectrum cefazolid, but less active against penicillinase producing staphylococci and H. influenza. Plasma protein binding is low and it attains high concentration in bile and is excreted unchanged in urine. T half is 60 minutes. Cefadroxil, it is a close congener of cephalexin and it has a good tissue penetration and exert more sustained action at site of infection, because of which it can be given 12 hours despite half-life of 1 hour. It is excreted unchanged in the urine and the dose need to be reduced only if creatinine clearance is less than 50. The antibacterial activity of cefadroxil and indication are similar to those of cephalexin. Second generation cephalosporin. They were developed subsequent to the first generation compound and are more active against gram-negative organism and with some member active against anaerobe as well, but none inhibit Pseudomonas aeruginosa. They are weaker than the first generation compound against gram-positive bacteria. Their utility has declined in the favor of third generation agent. Cefuroxime, it is resistant to gram-negative beta-lactamase and it has a high activity against organism producing this enzyme, including PPNG and ampicillin-resistant H. influenza, while retaining significant activity on uh, gram-positive cocci and some certain anaerobes, but not Bacteria fragilis. It is well tolerated by IM route and attains relatively higher CSF level but has superseded by third generation cephalosporin in the treatment of meningitis. It can be employed for the single dose IM therapy of gonorrhea due to PPNG. Cefuroxime exotic. It is a ester of cefuroxime and is effective orally, though absorption is incomplete. Activity depends on in vivo hydrolysis and release of cefuroxime. Cefaclor, it retains significant activity by oral route and is more active than first generation compound against H. influenza, E. coli, Proteus mirabilis, and some others. Cefprozil. This is a second generation cephalosporin, has good oral absorption with augmented activity against Streptococcus pyogenes, Streptococcus pneumoniae, Staphylococcus aureus, H. influenza, Moraxella, and Klebsiella. It is excreted by the kidney with T half of 1.3 hours. The primary indications are bronchitis, ENT, and skin infection. About third generation cephalosporin, this compound introduced in 1980s have high augmented activity against gram-negative Enterobacteriaceae and few member inhibit Pseudomonas as well. All are highly resistant to beta-lactamase from gram-negative bacteria. However, they are less active on gram-positive cocci and anaerobe. Cefotaxime. It is a prototype of third generation cephalosporin and exert potent action on aerobic gram-negative as well as some gram-positive bacteria, but is not active on anaerobe Staphylococcus aureus and Pseudomonas aeruginosa. Prominent indications are meningitis caused by gram-negative bacilli, life-threatening resistant and hospital-acquired infection, septicemia, and infection in immunocompromised patients. It is an alternative to ceftriaxone for typhoid fever and can be utilized for single-dose therapy of PPNG urethritis, but it is not dependable for Pseudomonas infection. Cefotaxime is deacetylated in the body and the metabolite exerts weaker but synergistic action with parenteral drug. Plasma T-half of cefotaxime is 1 hour but is longer for deacetylated metabolite, permitting 12-hour doses in many situations. Penetration into CSF is good. Safety zoxime. It is similar to antibacterial activity and the indication to ceftaxime, but inhibits bacteroid fragilis also. It is not metabolized, excreted by kidney at slower rate, and T half is 1.5 to 2 hours. About ceftriaxone, the distinguishing feature of this cephalosporin is its longer duration of action, that is, T half is 8 hours, permitting once and at most twice daily dose. Penetration into CSF is good and elimination occur equally in the urine and bile. Ceftriaxone has shown high efficacy in wide range of serious infection, including bacterial meningitis, multi-resistant typhoid fever, complicated UTI infection, abdominal sepsis, and sepsis. Single dose of 250 mg IM has proven curative in gonorrhea, including PPNG and chancroid. Hypoprothrombonemia and bleeding are specific adverse effect, and hemolysis is reported. About ceftazidime, it is the most prominent feature of the third generation cephalosporin is its high activity against Pseudomonas aeruginosa, and specific indication are febrile neutropenic patient with hematological malignancy and burns. Its activity against Enterobacteriaceae is similar to that of the ceftaxime, but it is less active on Staphylococcus aureus and gram-positive cocci and anaerobes like Bacteroides fragilis. Its plasma TF is 1.5 to 1.8. Neutropenia, thrombocytopenia, rise in transaminase blood have been reported. About cefoperazone, like ceftazidime, it differs from the other third generation compound in having stronger activity on Pseudomonas and weaker activity on other organisms. It is good for Staphylococcus, Salmonella typhi, and Bacteroid fragilis also, but more susceptible to beta-lactam. The indications are severe urinary, biliary, respiratory, skin, soft tissue infection, typhoid, meningitis, and septicemia. It is primarily excreted in the bile, T half is 2 hours. It has a prothrombonemia action, but does not affect platelet function. Disulfiram-like reaction with alcohol has been reported. About cefixime, it is a orally active third generation cephalosporin, highly active against Enterobacteriaceae, H. influenza, Streptococcus pyogenes, and it is resistant to beta-lactamases. However, it is not active against Staphylococcus aureus, most pneumococci, and Pseudomonas. It is longer acting and has been used in the dose of 200 to 400 mg BD for respiratory, urinary, and biliary infection. Stool changes and diarrhea are most prominent side effects. Cefpodoxime peroxide. It is an orally active ester product of third generation cephalosporin, cefpodoxime. In addition to being highly active against Enterobacteriaceae and Streptococci, it inhibits Staphylococcus aureus. It is used mainly for respiratory, urinary, skin, and soft tissue infection. Cefdinir, it is this orally active third generation cephalosporin, has good activity against many beta-lactamase producing organisms. Most respiratory pathogens, including gram-positive cocci, are susceptible. Its indications are pneumonia, acute exacerbation of chronic bronchitis, ENT, and skin infection. Ceftibuten is another oral third generation cephalosporin active against gram-positive, few gram-negative bacteria, but not Staphylococcus aureus. It is stable beta-lactamase. It is indicated in respiratory ENT infection. T half is 2 to 3 hours. Ceftamate pivoxib. It is a ester product of ceftamate, third generation cephalosporin, has high activity against gram-negative bacteria, especially Enterobacteriaceae, Neisseria gonorrhoeae, used in respiratory, skin, soft tissue infection, etc. About fourth generation cephalosporin, the distinctive feature of this last developed subgroup of cephalosporin is non-susceptibility to inducible chromosomal beta-lactamase, in addition to high potency against Enterobacteriaceae and spectrum of activity resembling third generation compounds. Fipime is developed in 1990. This fourth generation cephalosporin has antibacterial spectrum compound but is highly resistant to beta-lactam, hence active against many bacteria resistant to earlier product. Pseudomonas aeruginosa and Staph aureus are inhibited but not MRSA. Due to high potency and extended spectrum, it is effective in many serious infections like hospital-acquired pneumonia, febrile neutropenia, bacteremia, and septicemia. Higher concentrations are attained in the CSF and it is excreted by kidney with t-half of 2 hours. Cefpiron is a fourth generation cephalosporin and it is a treatment of serious resistant hospital-acquired infection, including septicemia, lower respiratory tract infection. Its deuteron character permits the better penetration into foreign channel of gram-negative bacteria. It is resistant to many beta-lactamase, inhibit type 1 beta-lactamase, producing Enterobacteriaceae, and it is a more potent against gram-positive and some gram-negative bacteria than third generation compound. Adverse effects are pain, diarrhea, hypersensitivity. Home test occur in many patients, but hemolysis is rare. Nephrotoxicity occur. Bleeding occurs with cephalosporin with methyl thiotetrazole or similar substitution at position 3. This is due to hypoprothrombinemia caused by same mechanism as warfarin. And it is more common in patients with cancer, intra-abdominal infection, renal failure. Then neutropenia, thrombocytopenia can reported with ceftazidime. Disulfiramide reaction can occur with cefoperazone. Uses cephalosporin are most commonly used antibiotic. Among them, they cover a wide range of gram-positive, gram-negative bacteria, including some anaerobes, but not Bacterius fragilis, MRSA, Enterococci, Mycobacteria, Chlamydia. Their indications are alternative to penicillin for ENT, upper respiratory cutaneous infection. One of the first generation compound may be used. Penicillin is producing staphylococcus infection, septicemia caused by gram-negative organism, and for surgical prophylaxis. First generation cephalosporins are popular drug. Cefazolin is employed for most type of surgeries, including those with surgical prostheses such as artificial heart valve and artificial joint. It can also be used in meningitis. Optimal therapy for pyogenic meningitis require bactericidal activity in CSF, preferably with antibiotic concentration several times higher than the MBC for infective organism. For empirical therapy before bacterial diagnosis, IV cefotaxime and ceftriaxone is generally combined with ampicillin and vancomycin. Ceftazidime and gentamicin is most effective therapy for Pseudomonas meningitis. Then it is also used in gonorrhea caused by penicillinase producing organism. Ceftriaxone is the first choice of drug for single dose therapy of gonorrhea if penicillinase producing status of organism is not known. Cefuroxime and cefotaxime has been used for this purpose. For chancroid also single dose is as effective as erythromycin. Then it is also used in typhoid. Ceftriaxone, cefoperazone injected IV are fastest acting and most reliable drug for enteric fever. They are preferred over fluoroquinolone for empirical therapy. Since many Salmonella typhi strain are resistant to chloramphenicol, ampicillin, cotrimazole, and fluoroquinolones. Then it is also used in mixed aerobic anaerobic infection in cancer patient, those undergoing colorectal surgery, obstetrical complication. Cefuroxime and cefaclor and one of the third generation compound is used. Then it is also used in hospital acquired infection. Cefotaxime, ceftriaxone, fourth generation drug may prophylaxis and treatment of infection in neutropenic patient. Ceftazidime and another third generation compound can be used in combination with aminoglycosid. Then monobactam astronam, it is a novel beta-lactam antibiotic in which other ring is missing but act by binding to specific protein binding pore. It inhibits gram-negative enteric bacilli, H. influenza at very low concentration and pseudomonas at moderate concentration, but does not inhibit gram-positive cocci and fecal anaerobe. Thus, it is a beta-lactam antibiotic with a spectrum resembling aminoglycoside, and it is resistant to gram-negative beta-lactamases. The main indication of astronam are hospital-acquired infection originating from urinary, biliary, and GI tract, female genital tract. Lack of cross-sensitivity with other beta-lactam antibiotic except ceftazidime is most prominent feature of astronam, permitting its use in patients allergic to penicillin and cephalosporin. Rashes and rise in aminotransferase are notable adverse effects. It is eliminated unchanged in the urine. Then carbapenem. Imipenem is the derivative of thienamycin. Imipenem is extremely potent, broad-spectrum beta-lactam antibiotic whose range of activity include gram-positive cocci, Enterobacteriaceae, Pseudomonas aeruginosa, Listeria, as well as anaerobe like Bacteroides fragilis and Clostridium difficile. It is resistant to most beta-lactamase and inhibits the penicillinase producing staphylococcus. Though some MRSA are inhibited, it is not reliable for treating such an infection. Limiting feature of imipenem is its rapid hydrolysis by enzyme dehydropeptidase 1 located on the brush border of renal tubular cell. An innovative solution to this problem is its combination with cilastin, reversible inhibitor of dehydropeptidase 1, which has matched pharmacokinetic with imipenem and protects it. Imipenem cilastin, that is FMJ IV6 hourly, has proved effective in wide range of serious hospital-acquired respiratory, urinary, abdominal, pelvic, skin, soft tissue infection, including those in neutropenic cancer and AIDS patients. For Pseudomonas aeruginosa infection, it should be combined with gentamicin. Imipenem has propensity to induce seizure at high doses and in predisposed patients. Diarrhea, vomiting, skin rashes, and other hypersensitivity reactions are the side effects. Then newer carbapenem metabolized by renal peptides does not need to be protected by cilastin. Imipenem is like imipenem, its activity against both gram-positive, gram-negative anaerobes as well aerobes as well as anaerobes. Somewhat more potent on gram-negative aerobes like especially Pseudomonas aeruginosa, but less potent on gram-positive cocci. Meropenem is reserved for treatment of serious nosocomial infection like septicemia, febrile neutropenia, intra-abdominal pelvic infection caused by cephalosporin resistant and diabetic foot. For Pseudomonas aeruginosa, it should be combined with aminoglycoside. The adverse effect of meropenem is similar to imipenem, but it is less likely to cause seizure. About poropenem, it is another carbapenem beta-lactam antibiotic that is orally active against most gram-positive, gram-negative, including some anaerobe. Streptococcus pneumoniae, H. influenza, Moraxella are highly susceptible. It has been mainly used in respiratory, ENT, and genitourinary infection. Usual side effects are diarrhea, abdominal pain, nausea, rashes. Doripenem, introduced recently, and this carbapenem has antibacterial activity similar to meropenem, but is more active against some resistant pseudomonas. Other properties including non-susceptibility to renal peptides as well as clinical indication are also similar to meropenem. Adverse effects are nausea, diarrhea, superinfection, phlebitis of injected vein. Seizures are less likely. Thank you guys.